almost every exam that you attend, a disorder in the spinal cord, not a complete but a half section of the spinal cord, known as Brown-Sequard syndrome. Don't forget, it's so common, and it's rather more common than the movie that you watch every time when you switch on your television set, the great legendary Suryavansham. So I always regard this topic as Suryavansham of all the topics that you get in the exam, Brown-Sequard syndrome. Let's try to find this disorder. What are the neurological deficits seen in such patients? If I know this disease, it's a hemisection of the spinal cord. Like I've got a transverse section in the spinal cord, and I have a disorder which involves not the complete but half of it, hemisection. What would be the neurological deficit at the level of the lesion? And what would be the neurological deficit below the level of the lesion? If you remember this topic, at the level of the lesion, the spinothalamic tract is lost on the same side, ipsilateral. But below the level of the lesion, the spinothalamic is lost on the opposite side, contralateral. At the level as well as below the level of the lesion, don't forget, the posterior column is lost on the same side, ipsilateral. At the level of the lesion, the weakness is of the type element on the same side of the lesion, ipsilateral. But below the level of the lesion, the weakness is of the type UMN, again on the same side, ipsilateral. So this is so common a topic, don't forget. Yes, Brown-Sequard syndrome, the Suryavansham of all the topics that you get in the exam, very commonly repeated. And don't forget, when the IPL finishes off, Hira Thakur and Bhanu Pratap ji will be out into their bus to chase you somewhere on the Setmax channel. So this topic should never become something which we saw in the Suryavansham movie, the legendary Zehar wali kheer. So let's try to taste the Zehar wali kheer of the Brown-Sequard syndrome in format of an MCQ. In this question or a clinical question, a 32-year-old male is brought to the emergency department with history of stab injury followed by difficulty in walking. And the neurological findings in the patient on his right side of the body and the left side of the body are like this. The right upper limb of the patient is having a power of 0/5. The deep tendon reflexes, the DTR, in the right upper limb, the biceps and the triceps, are absent. The tone of the right upper limb is decreased, it is flaccid. So one thing rings into your mind that this kind of a weakness in the right upper limb in the case is of the type what? LMN. In the right upper limb, the sensory loss is seen. The spinothalamic tract is lost. That means the pain, touch and temperature is lost in the right upper limb. Vibration, joint position sense. The posterior column sensations are also lost in the right upper limb of the patient. Now let's see the right lower limb. Right lower limb of the patient is having a power of 1/5 grade. But this time the deep tendon reflexes are 3+. That means they are exaggerated, they are brisk, they are not normal. The tone is also increased and the patient has got spasticity in the right lower limb. So any patient who comes to you with a motor deficit with hyperreflexia and spasticity, what comes to your mind? Yes, an upper motor neuron kind of a disorder. But in the right lower limb, don't forget, the spinothalamic tract is normal. That means the pain, touch and temperature is intact. But vibration and the joint position sense, posterior column is lost in the right lower limb of the patient. Now let's see the opposite side, the left side. The left upper limb of the patient is having a power of 5/5. The deep tendon reflexes are normal. The tone is also normal. But in the left upper limb, pain, touch and temperature is lost in the segments C7 and C8 only. While above that, C5, C6, it's normal. Posterior column is also normal in the left upper limb. Now let's look at the left lower limb of the patient. The power in the left lower limb is 5/5. The deep tendon reflexes are normal. The tone is normal. but the spinothalamic tract, that means the pain, touch and temperature in the left lower limb is lost. Posterior column is also normal. All this happened because the patient has suffered what? A stab injury. So look at this patient now again. If someone suffers a stab injury, you can have a transection of the spinal cord. May not be complete, but a hemisection. So at the level of the lesion, we get element weakness. Below the level of the lesion, we get UMN weakness on the same side, ipsilateral. At the level of the lesion, the spinothalamic is lost. Yes, on the same side, ipsilateral. Below the level of the lesion, spinothalamic is lost on the opposite side, contralateral. At the level below the level of the lesion, posterior column is lost on the same side, ipsilateral. Correct? Now, let's try to find this out. Why LMN and why UMN? This is a very common query by any student, sir. Why LMN, why UMN? I don't understand in myelopathy disorders. You know, if I see this as two transverse sections of spinal cord, one above, one below, I know this. They're connected to the brain or the cortex through a tract which starts in the cortex, ends in the spinal cord. The corticospinal tract. Yes. The corticospinal tract, if you remember, crosses the midline above the spinal cord in the lower half of the medulla, the brainstem part. Now it stops at a gate anterior horn cell to become a nerve for a perfect muscle. Same goes for the segment below as well. Now I am telling you this basic concept because if at all you have a hemisection in the spinal cord, at the level of the lesion, the anterior horn cell is lost. And if you remember your basics again, whenever there is an injury in the anterior horn cell, the weakness is seen of the type LMN. So at the level of the lesion, we get an LMN weakness. The tone of the limb in LMN is decreased, flaccid. The reflexes are also lost. But below the level of the lesion, if you remember, the corticospinal tract for the segment below is affected, not its anterior horn cell. So whenever you have an injury in the corticospinal tract, don't forget, you have the weakness of the type UMN. So below the level of the lesion, you will find spasticity and hyperreflexia, right? So at the level of the lesion, it's an LMN weakness. Below the level of the lesion, you always get a UMN weakness. In a case or a disorder affecting the spinal cord, myelopathy. But the biggest query here is, sir, this LMN and this UMN will occur on which side? Will it happen on the same side of the lesion or the opposite side, ipsilateral or contralateral? Now look at this diagram again. If I have an injury on the left side of the spinal cord, of course the left anterior horn cell is affected. So only the left side of the body will show flaccidity and areflexia. So LMN weakness at the level of the lesion in hemisection of the spinal cord, of course, will always happen on the same side, ipsilateral. Below the level of the lesion again, corticospinal tract is affected on the same side, ipsilateral. So don't forget this old funda, that whenever there is a lesion below the medulla, right, and it affects the corticospinal tract or the spinal cord, in a section which is not complete but half, hemisection, you're going to have LMN and UMN on the same side, ipsilateral. And don't forget this connection again. If you have a lesion above medulla in cortex, then you find the weakness on which side? Contralateral weakness. So this basic should be very clear in your minds, because without this basic you cannot build up the concepts of myelopathy. Now what happens if you have a hemisection in the spinal cord as per the sensory tracts? For this we'll do a diagrammatic representation of not one but 4 segments of spinal cord. C5, C6, C7 and C8, all cervical, the low cervical. If you know the spinothalamic tract, yes, which carries the sensation of pain, touch and temperature, would cross the midline in the anterior half of the spinal cord, but not at the same level. 2 segments above the point of entry. So for example, I want to show this. The spinothalamic of the C8 segment would cross the midline in C6, right? The spinothalamic of C7 segment will cross the midline in C5. The spinothalamic of C6 segment will cross in C4. C5 will cross in C3. So the basic concept again, the spinothalamic crosses the midline in the interior half of the spinal cord, but not at the same level. 2 segments above the point of entry. So what about the posterior column? Carrying up the sensation of vibration joint position? Where does it cross? It doesn't cross anywhere in the spinal cord. If you remember, it crosses the midline above the spinal cord in brainstem medulla, right? So this is what we know already. Now look at this. I've got a hemisection in the spinal cord. Yes, in the C5 segment and the C6 segment. So the spinothalamic loss will occur below the level of the lesion on which side? Contralateral side. That's correct. But will the contralateral spinothalamic tract at the level of the lesion will be affected? At the level of the lesion? No. They remain intact. At the level, below the level, don't forget. What is affected? The posterior column. Fine? So this is a hemisection of the spinal cord that we see. So finally, where is the lesion? As I've shown in the diagram just prior to this, is the lesion in C5 and C6 segment, C4 or C5 segment, C7, C8 segment, or the lesion is C5 and C8. Let me recall again. In the left upper limb of the patient, yes, the C7 and C8 segment spinothalamic were lost, but C5 and C6 were intact. So the biggest question after a stab injury, lesion किधर है? Oh my God, auntie is also back. Lesion कहाँ था? Not रसोड़े में कौन था? Lesion कहाँ था? She has got a different agenda. Now I think the answer is best is C5, C6. Yes? No. अफसोस गलत जवाब. इतना गलत कैसे हो सकते हो भाई? Right? You think that there is a hemisection in C5, C6 only. That's why C7 and C8 segment on the opposite side of the patient are lost. Kuch bhi. Anything that comes into your mind, you will answer it. Do not ever answer the question in a hurry. Okay? Let's try to focus this. One thing is very clear. C5, C6 segment, if at all is lost, at the level of the lesion, we get an element weakness. If you remember, the biceps jerk which we checked in the upper limb was lost, correct? So that's very clear, the lesion is in C5, C6. But the right upper limb doesn't only have a biceps jerk to be tested. It also got one more jerk. Yes, the triceps jerk. That has got a root value of C7 and C8. That is also lost, right? So my dear friend, in this particular case and a question that I've shared with you, the lesion is not only in C5, C6, it's C5 to C8. That very well matches with the description given in the question, right? So finally, if I look this question in the exam, it will come like this. Oh my God, such a complicated thing. I've tried to simplify in a diagram like this, correct? So what is the most probable site of the lesion? C5 to C6, hemisection, right side. Hemisection, right side, C4, C5 segment. Hemisection, right side, C7, C8 segment. Hemisection of the cervical cord on the right side, C5 to C8. Yes, the correct answer is D. Now, the common thing that comes into a student's mind, again, sir, it's very difficult to remember the root values. I've got an easy rhyme for you to remember the root values of all the reflexes. The commonly tested one. The rhyme goes like this. 1 and 2, buckle my shoes. 3 and 4, kick the door. 5 and 6, pick up the stick. 7 and 8, shut the gate. Buckle my shoes. I try to wear my shoes by buckling it up on the heel, somewhere close to the ankle joint, right? So at the ankle joint, we do a reflex which is known as the ankle jerk. Now what's the significance of the word number 1 and 2? The root value of the ankle jerk is S1, S2. Kick the door. You kick the door by extension of what? The knee joint. And you find the extension of the knee joint in which reflex? The knee jerk. And what's the significance of 3 and 4? The root value, L3, L4. Pick up the stick. You want to pick up a stick and hold it, right? For picking up a stick, you need to flex the elbow. Inflection of the elbow by the contraction of the biceps muscle will happen in which jerk? The biceps jerk. And what's the significance on 5 and 6? The root value, C5, C6. Shut the gate. You want to shut the gate by extension of the elbow joint. And which reflex will show it? The triceps jerk. Number 7 and 8, why? The root value, C7, C8. So easy rhyme to remember the root values of major reflexes that you want to see in a patient. But listening to this rhyme, one thing comes into your mind. Sir, I want to go to school. Don't worry. Kira Thakur has said a new bus driver, Sonu Sood. He will do a better job, right? Now let's try to see them individually. Like for this is an ankle jerk which has got a root value of S1, S2. We take our knee hammer, we strike it on tender Achilles. We find the dorsiflexion of the foot happening, but most important, the contraction of the calf muscle are to be seen. The ankle jerk. Now the biceps jerk, we tap the knee hammer on the biceps tendon. There is flexion of the elbow and contraction of the biceps muscle that is seen. Then we have the knee jerk. We tap the knee hammer infrapatellar. We find the extension of the knee joint and of course the contraction of the thigh muscles. Then we have the triceps jerk where we tap the knee hammer on the tricep insertion. Yes, we find some extension of the elbow and the contraction of the triceps muscle. So don't forget the rhyme. 1 and 2, buckle my shoe, ankle jerk. 3 and 4, kick the door, knee jerk. 3 and 4, L3, L4. 5 and 6, pick up the stick, biceps jerk, C5, C6. 7 and 8, shut the gate. Triceps jerk, C7 and C8, right? I am very sure that you must be worried. Sir, is it compulsory to show memes with every topic? It tries to distract me. My dear friend, yes, memes speak louder than words sometimes. I need not talk that much, which you can see in a meme. Yes. Like for example, you see this picture, what comes into your mind first? 2nd October, they went to Panjim. 3rd October, they returned from Panjim. And what did they do in Panjim? They eat something. Biryani. Of course, not the veg biryani. Pav bhaji. And of course, at the end of the movie, we keep on thinking, where is Sam? Oh my God. The nation wants to know. Mujhe answer do, mujhe answer do. Say no to drugs. Say good. Yes to questions maybe. So in this COVID time, happiness and time on an axis, if I try to plot it. You know what happened when the COVID cases started increasing? The government announced a lockdown. And unfortunately, we did not have any offline classes. We did not have any interaction with the teachers. So happiness quotient went down. But with time, what happened? We tried to mold ourselves, and something which came as a new normal are the online classes. And e-medicos, we started doing it. So happiness quotient increased. But further the cases increased, our happiness quotient went down. Then the unlock happened. Oh my God, I was so happy. I can see so many people around me now. Happiness quotient again increased. Then the mid-year, the pandemic exam happened, the AIMS and the PGI. Some of the students did not get selected. The happiness quotient went down with time. And further cases increased, as you know. Our happiness quotient went further down. But one day we got a news of DAMS DVT. Yes. And suddenly when you attend DAMS DVT, I'm very sure